Without further ado, I'd like to introduce to Kira. Like I said, Kira is a hospice staff member. She has over 11 years of experience in social work. Kira is an advocate for palliative care and someone who has helped many, many patients and their families navigate life-limiting illness. So, and Kira's also going to help us understand some of the acronyms that she has after her name so that you all know what her credentials are for this program.
Thank you, Sarah. So I'm a clinical social worker, and I also have a certificate in thanatology, which is just thanatology, as you may know, is the study of death and dying. So that's just a certificate, especially in death, dying, and grief. And the other certificate represented is an advanced certificate in hospice and palliative care for social work. So jumping in. Again, thanks everyone for being here. I am always happy at how many people are familiar with HospiCare's hospice service in our community, serving Tompkins and Cortland counties. Today we're going to be talking about palliative care, and before we jump into that, just as this slide points out, hospice care is obviously part of our name and what we've been doing for decades in Tompkins County, and that's all types and all levels of support for people who are facing the end of life. We also offer grief support. We have an incredible bereavement program, which is for the families of our hospice patients. And also we have a community program so that anyone in our community, after any type of loss, after any amount of time, can receive support from our bereavement counselors, our groups, and counseling, our special events. And as I said, so today we're going to be really focused on palliative care. And palliative care is used all different ways. It really means a focus on quality of life. So hospice care is a form of palliative care. Hospice care is a focus on quality of life at the end of life. When someone has a terminal diagnosis, when someone is facing the end of their life. But palliative care actually has a broader purpose and can come at lots of times of life for people. So it can be a time when someone has, say, a life-changing medical diagnosis. So let's say that someone gets a diagnosis of cancer, or a chronic illness has taken a more complex turn or a more serious turn, and maybe symptoms are changing. Palliative care is a way to address both the physical and medical, the psychosocial, the spiritual needs at a time where someone's medical situation is really significantly changing. We could go to the next slide. Hopefully what we'll say today will kind of flesh that out a little bit. So we have, in fact, to start, a testimonial video, which is a story that will help illustrate some of these principles that I was just saying.
Sure, just give me a moment to get that started.
I know, I heard you, but I couldn't get you. I couldn't. I had the video.
Palliative care Palliative care comes from a word palliation, and palliation really means improvement. So, palliative care tries to help the patient with the symptoms, whatever the symptoms are, whether they're physical symptoms, emotional symptoms, social needs, spiritual needs, community based needs. Hospice is a very tiny subset of palliative care. So, hospice is for people who have advanced illness and who are likely to pass within the next 6 months. So, the way I think about it, there's a small kernel of hospice and there's a huge circle of palliative care. And the huge circle of palliative care is that's what could make your life better. And as your illness progresses, you may end up in that small kernel of hospice, but the big circle of palliative care is that's what we're trying to help you with. Palliative care is beneficial to anybody, regardless of prognosis and regardless of age, when you're facing any kind of serious illness.
They realized as a family that they really needed to have as much support as possible under these circumstances, and actually they moved back to Ithaca.
Palliative care works with your treating doctor, and when you elect to get palliative care, you don't give up your treatment options. You still continue on treatment. And many people who get palliative care continue to get their chemo, continue to get their radiation, take the medications for heart failure, go to the cardiologist. So a lot of time in medical encounters, there's not enough time to focus on your personal experience on illness, on your family's experience, and all the additional needs that come along with being seriously ill. So many times when people go and see a specialist, the discussion is about medication management, what's the next plan, and a lot of the stuff that's actually really important to people and to their quality of life does not get fully covered because of time constraints. And that's where the palliative care really steps in, because it could make a huge difference to your quality of life if your symptoms are well controlled, if your family is supported, and if the patient understands the trajectory of the illness and what's waiting for them, and if they can make plans according to where they are when they really understand what's happening to them.
Having professionals there who can provide palliative care, not only for the individual, but for the loved ones around them, who in their own way are going through profound pain, and just everything in their being is fighting the notion of accepting the reality and accepting the situation. And so just support in navigating that journey toward a goal of peace of mind for everyone, and enjoying each moment, celebrating each moment, and not bearing the weight of the reality in every moment is something that people who really understand palliative care can enable.
I think it's important to build a team, and I think that's what palliative care can do, is help individuals build a team, knowing that they have life-limiting conditions, so that they reach that point of peace of mind that Paul referred to.
Okay, so you saw Dr. Yender on the video, who illustrated this really beautifully already. This is that same image she was talking about and that I described, where hospice is sort of under the umbrella of palliative care. It is about addressing comfort and about evaluating symptoms at each layer of our humanness. But palliative care is a much bigger circle, and there might be a point, as I said, at a time of diagnosis or at a time where symptoms really significantly change. When palliative care as a consult or as really being part of our palliative care program can help to make life better, can help to make it easier to understand different medical choices, to look at advanced directives, to address some of the existential questions that come with changing symptoms and a diagnosis. So palliative care just can be provided anywhere. It might be a time when someone's in the hospital and gets a referral at that time, again, due to information that comes out at the hospital or at a medical appointment. It can also be provided at home or on site at any facility that someone might be at. It's also something that people can pursue themselves. So for example, someone could call HospiCare themselves from home or from anywhere they are to say, I think I might really benefit from the care that HospiCare provides with this program. And then we can do the rest to get the referral from the doctor and to come out and evaluate and talk with you. So it can be provided anywhere, and a referral can come from anyone. So what is it exactly? There is a medical component to it. Our palliative care program does include a nurse and Dr. Yander also to really look at symptoms and look at what impact an illness is having, the progression of illness is having, and to look at those with the lens of how to make life better, whether that be that someone is pursuing curative treatment, maybe someone has cancer, maybe even a new diagnosis, and is pursuing all types of curative treatment, but also wants to look at the symptoms of that and understanding the illness and its progression, understanding what to expect, and how to maybe stay a step ahead of what will be happening with the illness, and even say emotionally or spiritually the impact of that illness on the patient themselves or on their loved ones. So as this says too, and as we've shared, that this is a type of care that's available to anyone at any age and at any stage of a serious illness. So to exemplify that, I just wanted to tell a story from working with a palliative care patient at HospiCare. A referral for this patient actually came from a caregiver, as there had been just a lot, the patient themselves had dementia and was being cared for at home. And the caregiver really began to just have more and more trouble providing care. That's one way that we can tell that a disease is really changing, is that the symptoms, sometimes the patient is unaware of some of the symptoms changing. Sometimes it's the caregiver who notices, I'm having to do a lot more, and maybe even suddenly a lot more. Or, I hadn't noticed, but 6 months ago, I wasn't doing all of these things to care for my loved one. So our care for the patient began there, and both in looking at how many doctors was the patient going to and what purpose were those doctors' visits really serving, And how could we be helpful to the family in terms of reevaluating what medications were really working and really not, and reevaluating goals of care at that time, looking at advanced directives, completing documents to help the family kind of look at what was really important at this point. And then really helping the caregiver to provide support for the caregiver ourselves, but also to have the caregiver have someone to call at the time of need besides some of the specialists that the patient was seeing, someone who he could talk to and share what might seem like not enough to take the patient to a doctor for, but something that was still concerning to him. And helping him connect with some support groups and some resources in the community that could really ease his burden as a caregiver. So that really helped the family for probably close to, I want to say, maybe 9 or 10 months until we began to see from our palliative care nurse staying in touch with the family, really could see the symptoms beginning to change again. And it turned out at that time, and within a couple months from them, it was really time for that patient to come onto hospice. And it did turn into a time where the patient was facing the end of life. But a disease like dementia can be one of those that has a pretty variable timetable for changes and plateaus. So in that case, having our support right alongside for close to a year really helped the patient and her family through all that happened that year, but also helped them be ready for what was coming next and much more prepared for the swell of support that hospice provided. Okay, so I'm so pleased I get to be here today with Dr. Yander, and I get to turn things over to her right now. She's our medical director for hospice and palliative care, and she's also a practicing physician in our community and really incredible at what she does. She's really passionate and really knowledgeable, and we're really lucky to hear some more of what she can share with us today.
Thank you. I hope I can fulfill the expectations which have been set unnecessarily high. I would ask Sarah to start the slideshow. What I wanted to chime in are some of the diagnoses that are appropriate for palliative care. I think that our presentation may be kind of too vague in some ways, and I felt that it may be useful for some of the participants to have sort of a tangible idea, like what are some of the problems that we see. Palliative care can really be used for anybody. Unfortunately, there are some kids who have serious illness and who use palliative care services. I mean, most of the time people get ill as they get older. So a lot of the illnesses that will be listed are, afflictions that happen usually when people get older. One big bucket is heart disease. Congestive heart failure can cause a lot of symptoms, and the trajectory is sort of variable over the course of illness. It's one of the prime examples when palliative care can help. Angina, if people have intractable heart disease and there are no further surgical options or interventional options, either thought or possible, that is another prime target. Valvular disease, aortic stenosis is a very common one, especially in older people who can't have surgeries. And sometimes hypertensive heart disease, common affliction, and people can get a lot of symptoms based on that. Lung disease is another big bucket that we see a lot. COPD, people who have advanced COPD can be ill for many years and have a lot of symptom burden and can use a lot of support. Obviously, lung cancer, asbestosis, pulmonary fibrosis, those are not that common, but COPD is one of the most common. Could you forward the slide, Sarah, please? Kidney disease is pretty common. Kidney failure on its own, there are plenty of elderly people in a community who have really advanced kidney disease, who don't go on to get dialysis and actually can live for quite some time. But there's a lot of, pill burden and symptom burden that can be addressed. Dialysis, especially if people decide to go off dialysis, they usually transfer directly to hospice, but there's a role for palliative care in dialysis, again, because there's a high symptom burden, high medication burden. That is one of the prime examples. Obviously, palliative care is provided during cancer treatments. Part of the accreditation of the cancer centers is the provision of palliative care. A lot of this is provided directly in the oncologist's offices. We are called sometimes as a backup to help people evaluate different symptoms and how to best treat them and what is the next best trajectory. So we listed all kinds of common cancers that require our presence. Could you forward the slide, Sarah? These two, again, big buckets are the ones that sometimes people don't think about, but these diseases come with a very high caregiver burnout. Neurological problems, dementias, Alzheimer's, Parkinson's, stroke, cerebrovascular disease, multiple strokes. A lot of these illnesses last years as they progress, and people have a lot of symptoms along the trajectory. And this is where I feel palliative care can make a huge difference, connecting people with community-based resources, evaluating goals of care, evaluating intensity of treatment. So this is a big place where it can make a huge difference. And then another sort of last bucket, but an important bucket, is we call it geriatric syndromes, for lack of a better term. And this actually happens to a lot of people when they really are up in age, and it's just frailty. Frailty is a medical diagnosis. Well, how do you tell somebody's frail? Well, they get weak, they can't walk as well, they have decreased resilience to multiple stressors. And frailty significantly increases the burden on caregivers. So this is one of the situations when having palliative care backup could be really, really helpful. What happens to people when they're frail? Well, they fall, they lose weight, they may have cognitive decline, they fail to strive. Sometimes people feel like, well, how can I call somebody for help? There's no identifiable illness. But some of these geriatric syndromes are, this is the problem that people are facing, and it can really take a lot of resources, and the input could be valuable. That's what I have to say about the different illnesses that we see or that we encounter, just that people have a better idea what is it that could be helpful.
Great. So, so from there, so let's say that someone does have one of those diseases or is experiencing symptoms from that, as Dr. Yander was describing. What could someone expect being in touch with Hospicare for the palliative care support? So the first thing is that someone would be in touch by phone, say, if someone were referring themselves, or is going to be in touch with whoever the referral source is. And we're going to take it from there to do what we need to behind the scenes with doctors to affirm the referral. And then you're going to hear, a person would hear from our palliative care nurse. And that person will talk with someone on the phone and be in touch right away. And that would be the start of the program. From there, that nurse is going to be in touch periodically over time is going to regularly stay in touch with a patient, their family or caregiver, wherever it is that they are, whoever's taking care of them. And from both that initial time and then maybe changing over time to adjust to what things are coming up over time. And what does that patient, what does that caregiver family or that the caregiver circumstance need as things might be changing over time. So we're definitely going to be focusing on symptoms and how to have someone have the best symptom management they can. We do work alongside curative treatments, as this says, including chemotherapy or dialysis. Those are two really common ones we get questions about. If someone can still be doing those treatments and have palliative care, absolutely. We would be helping with the symptoms associated with that and with the impact that that ongoing treatment has on the patient, on the family, or the care situation. And then helping to evaluate choices that inevitably come with those treatments. We can always graduate someone off the program, someone who might be pursuing chemotherapy and have our support to help with symptom management, caregiving, so forth. And then maybe they are no longer on chemotherapy and they're just going back to life, not doing any kind of treatment, not with disease. We can help with, as I think we've said, with treatment choices. Sometimes being in an oncology office or with at a neurological appointment, sometimes information comes very quickly with terms maybe we don't understand or things that come up at the time we don't even know to ask a question about, and only later do we kind of begin to process what's going on. Our palliative care program is something to help kind of slow that process down and to help really consider, not from the momentum of our medical system and all of the things that they can offer and they can do, but actually helps people understand what a treatment choice might really look like in their specific situation, and helping a person really evaluate how that matches up with their values, thinking of alternatives that maybe weren't presented in a hospital setting or in a kind of just a purely medical setting, so that it can really feel like there is a choice and people really can become aware of how many choices there are, even though in an appointment it might just seem like one direction is presented. And then, of course, we collaborate. We have strong relationships with the providers, with physicians, with facilities in our community, in Tompkins County and in Cortland County, and we frequently collaborate with them to try to come to what's best for the patient. We can help with advocacy, we can help with communication, and we can also help, as I described in the story I told, helping people look at advanced directives. That might be helping people just consider the questions that come up with advanced directives. It might be just thinking through some of those options, and it might be actually pursuing the legal forms or the forms that would help to medically determine care. Power of attorney, things like that as well. Okay, next slide. So these are just a visual of some of the things that we've been talking about. Working with our palliative care program, as I mentioned, does mean working with a nurse and can mean working with Dr. Yander to really have that medical focus on the physical component of life. We also want to help and can figure out what's needed for, I think this sort of social category I'd put as kind of the network of support that someone has, and whether that might need some bolstering, and also looking at caregiving, at that sort of just our connection with other people and what both the patient and the care situation might need. That can be with, it might well be that the nurse is helping with some of those components. It might be that a social worker comes in to help with some of those specifics. It also might be that there's some existential questions that are brought up. And we do have a spiritual care coordinator who can come in to help and basically do a consultation to meet with the patient and family. She might also help someone connect to a faith community. Maybe they've been a part of a community at a certain time and they'd like some help reconnecting. They'd like someone to communicate on their behalf to help a spiritual or religious community or clergy person be connected to their situation at the moment. And then, of course, the many emotional components, again, for the patient, for the care situation, helping to address the many things that can come up in that arena. And of course, all of these things are so interconnected, times where something that manifests physically is related to emotional, spiritual issue, and so forth. So we really seek to support the whole person, all the components, including that care situation. Okay, so we want to help a patient and their family set goals for what it means to them to have the best life possible. What does quality of life mean for someone now, given the situation that they're facing, the diagnosis, the treatment change, and so forth? As I said, we do have nurses, nurse practitioner, doctors who are trained, just like as I had talked about some of the special training that I have. Our palliative care nurse, our other support people are also specially trained in comfort care. Social workers like myself might help connect a family with help with the many forms. It might be someone's applying for Medicaid. It might be someone wants to apply for a nursing home or figure out help to go from a nursing home to home, that sort of thing. And also, as I mentioned in my story, connecting with community groups or other emotional supports that the caregiver might really benefit from, as well as our spiritual care coordinator, figuring out what a patient might need and how to help. Next slide. Okay, so palliative care and its costs. I'd love to maybe bring in Kirsten on this question to speak specifically about these costs. Kirsten, would you chime in?
I'm sorry. Sorry about that. Oops. I think Sarah just started my video and then I stopped it. So currently there is no charge for any palliative care services that you receive through HospiCare. We have both the PATH program and we have the palliative consultations with Dr. Yander. Dr. Yander's consultations can be billed to insurance companies. But right now there is no charge for the PATH program. That may change down the road. But that's basically it as far as what it costs.
Kirsten, can you just tell us a little bit more about the PATH program and what that stands for?
Sure, I'd be happy to. So PATH stands for Palliative Approach to Health. And often when I call you, if you get a message from me, I will say the palliative program because PATH doesn't translate over the phone very well. And people often say, where are you calling from? But it's Palliative Approach to Health. And we provide an in-person consultation for the first visit when we sign somebody on. I review everybody's medication lists, what the situation may be with the person at the time, any symptoms they may be having, what kind of doctor's appointments they're visiting, and what their goals of care are, what they want to get out of any services they receive through either curative treatment or non-curative treatment, just focusing on the symptom management. And then, like I think Kira alluded to, I do touch base. I try to touch base at least once a month. But it can be as frequently as you want it to. Whenever you're on the program, you have 24-hour availability to our services. So you can always call in and speak to a nurse at any point with any questions that you may have regarding the illness or the situation that you have that may be causing some difficulties for you.
Great. So I think let's open it up to questions. We're so fortunate to have such an awesome interdisciplinary team with us. We've got Dr. Yander, Kira, social worker, and Kirsten, a nurse. So we've got a couple of questions that have come in through the Q&A, and I just want to invite all the participants and attendees to really, this is your time to ask these very experienced people any questions that you may have for yourself or a loved one. Our first question that we have, actually these are two questions associated with stage 4 liver failure patient. So the first question related to that would be if Hospicare, if our palliative care program works with someone that is having stage 4, either with or without a possible transplant. And then the second kind of tag-on question to that patient is what type of expectations could come with a diagnosis of end-stage liver failure? So I'm not sure who would like to take that, Kirsten or maybe Dr. Yander, but.
I mean, we absolutely work with stage 4 liver failure patients, either with or without the possibility of transplant. Like we said, you know, it's any person at any stage of the disease process. No matter what your goals of care are, we will work with you for sure.
Great, thank you.
In terms of what you expect, you know, it's variable, but a lot of the times clinically, when your liver doesn't work well, it has indirect effect on your brain. It's called hepatic encephalopathy. We don't have to talk about the terms, but people's thinking is not as clear, and it makes it difficult sometimes, and they need more help because they have more difficulty kind of manage their everyday life. People can be developing fluid buildup either in their stomach or in their lower extremities. Occasionally, people can develop kidney failure on the basis of liver failure. There are some other specific complications, bleeding from the gut. So those are the most common things that you would see. And absolutely, as Kirsten said, this is a prime example of where palliative care could be helpful because there's a high burden of symptoms with liver failure.
Great, thank you, Dr. Yander. Anyone else want to add anything else in relationship to that question? Okay, so our next question I would say is probably something that caregivers come across fairly often is that caregivers and the family support unit is ready for help, but the person experiencing the symptoms is maybe not ready for help. And so this participant says that their 86-year-old father has a plethora of issues, and his wife of 60 years recently passed in last April. And so when the family tried to access palliative care support, it didn't work because their father would say that he was fine whenever the nurse called. So he was resistant to receiving the support. Do any of you have any suggestions about how family members can?
Yeah, so you are not alone out there. This is not an uncommon situation. When people are cognitively intact, when I call up as the palliative care nurse, I have to speak to the patient. And if the patient tells me one thing, I have to go by that. if they're not cognitively intact, or if they are cognitively intact and allow for other family members to be involved in the whole care process, then I can, I could call up your father and I could touch base with him, and then I could say, I'm just going to touch base with family member X to see what their version of the situation is, to see if everything really matches. As long as everybody's on board with that, that can be a really great way to get the care that's needed. Again, the patient has to be willing to let that happen. Some people don't want me to contact any family members and make that very clear that this is their thing and they don't want anyone else involved. And so in that respect, it does make things more difficult. But as long as everybody's on board and I'm allowed to speak to whomever I can to get information about a situation, I definitely do that.
If I could chime in on a practical level, it's where what Kirsten was saying, as a family member, or if I have the situation like this in the office, the person said, I'm just fine, I really don't need anything. But you see all the family members there, like in the background, rolling their eyes and saying, well, this is not the case. What I tell the family members, use the I statement. I am worried about you, and I want this to happen, and at least get the assessment. And it's really difficult to argue with the I statement. This is, I am worried about you. That it's your feeling, and sometimes people relent, and many times when they relent, they're actually happy they have done it. Because it identifies all these problems that you didn't even know about that now can be addressed.
I would say probably 25% of the patients we have on right now are that kind of a situation. Well, okay, if you think we need it, we can do it. and the caregivers are always very relieved to have the support. So, yeah.
Anything else? Okay. Next question. When is it time to call for a palliative care consult?
Anytime. If you have a question, you can just call up and we can get the process started, and we will call you and find out more about your situation and let you know if it's appropriate or if it's not appropriate. And so if you ever have a question, don't hesitate to call. I'd much rather you call and not be appropriate than wait too long.
Awesome, thank you. Next question. My father has fibromyalgia and chronic pain. Would palliative care be something that he could benefit from?
Okay, I will take this. Yes, palliative care is something that he could benefit from. Our palliative care program doesn't necessarily deal with people who have chronic pain issues as their primary diagnosis, but depending on what else is going on, we could definitely discuss and see what is going on and see if we could be of help in the situation. If not, we could definitely we could refer you on to somebody else who could be.
Yeah, if I could chime in, that is absolutely correct. We're not functioning as a pain clinic. If, when people with chronic pain, it's usually not just the chronic pain, there's depression, anxiety, social issues coming along, and that would be the primary target. The pain management per se, we can make recommendations, but we do not take over chronic pain management. That is the role of a pain clinic.
Great, thank you. Just putting a last call out there for any final questions. If anyone has any, we have time for one more. Great. One more question. How does palliative care support the family? As a caregiver, I feel like I'm the one who needs the help the most.
Well, like I was saying, a lot of our patients really, the patients don't really feel like they need the help, but the caregivers are the ones who are overwhelmed and either need answers or need help getting referrals to other agencies in the area, or just having somebody in their back pocket to know that they can call at 3 a.m. if something is going not right and they need some support. So often it is the caregivers who need help more than the patients, or at least the caregivers that realize they need help more than the patients. So we are there, like I said, 24/7. You can call us whenever there's a question. Again, like I said, if your family member is open to having it be, a collaborative situation, I can talk to everybody involved in the situation and try to help, make suggestions or get more information for you. So it's definitely appropriate for family members of people with chronic illness as well. Or, yeah. Any questions, just reach out, please. I'd be happy. I can, I don't think my contact information is on here, but it is on the website. So if you have any questions, feel free to call and ask for me. You can also just ask our intake coordinator, and she can give you just a basic rundown as well. So.
Nice. Anyone want to add anything? Is there anything specific support that a caregiver would receive through palliative care?
I think
Well, go ahead.
also what helps a lot is, a list of resources of the local agencies, Alzheimer's Association, Office for the Aging, just connecting people to resources. And I think that, I certainly see it as doctors, we underestimate the burden it takes to care for somebody who's seriously ill. And I think that the caregiver support should be always, always on our radar screen, because it really takes a village, and if it's only one adult child who's trying to do all of it, it's just it can be extremely burdensome.
Yeah, I just wanted to add, I think one of the things that all of us really bring to any patient and family that we serve is a lot of experience, and having seen a lot of people and a lot of families through both a disease progression and also caregiving progressions. And it's I think sometimes can get hard. It can feel like you're just kind of in a vacuum in a situation, and having someone from our team come in who really kind of knows the landscape of the situation and can help to talk through, just like when I mentioned about talking, slowing down the questions around treatment decisions. The same thing goes for caregiving decisions, of going through sort of what the different options are available, what they really look like on the ground. How do you even access those different supports? So just having someone who's available like that with just a lot of experience, and as Dr. Yander said, is sort of already aware of the different resources and knows how to access them, can go a long way. And I think, as Kirsten talked about, just being regularly in touch with a patient and whatever care team is around who's allowed to have contact with us, that contact does also form a relationship with a family and with a patient. And that's one of our most powerful tools also, especially in palliative care, especially when we have a longer length of time with a patient and a family, where things can come up, be brought up in the situation. That one-time visit at the hospital or at an appointment can feel intrusive or sudden or scary. When someone that you've gotten to know and who does come with a lot of experience, sometimes it can just, the approach with which different options are brought up can also really change how they're received.
That's great. Thank you. Anyone else want to add anything?
I always tell people, if you have a serious illness, you're shooting at a moving target. Your care needs, your medical needs change. And as they are changing, that it's always good to get more support. You can't go wrong by asking for more help. And I'm thankful that the program is there for you.
Thank you. Well, thank you, everyone. Kira, Kirsten, Dr. Yander, this has been a fabulous discussion. And thank you again to Lifelong for hosting us this evening. And thank you to everyone for joining us. We're going to send out a short survey along with the slides and recording of the webinar. So we'll get that out by the end of the week. And really, like Kirsten said, you're welcome to reach out to us at any time. You can send me an email. I've corresponded with all of you. So if you want to, and I can forward anything on to Kirsten or Kira, Dr. Yander, if there's anything I can't help with. And of course, you're always welcome to just call us. We're at the office 8:30 to 4:30 for those kinds of calls, and the number is 272-0212. So again, any of these conversations can happen. We have a really great intake person named Sandy, and she's just a wealth of information as well, and she can direct you to anyone that would be able to have a more in-depth conversation about palliative care, hospice, grief support, and also advanced care planning. So we'll end there, I think, and just again, thank you all for your interest, and reach out anytime you need us. Take care. Have a good evening.